Hello and welcome to the Processes and Documentation in the General Surgery module. First, we will look at admissions. This will be one of the core tasks required from you. Having good documentation skills and clerkship skills are going to be an advantage throughout your training. Patients from the surgical divisions are admitted either from the emergency department or the outpatient surgical clinic, or also known as SOPD. Don't be surprised, as you also may have to see patients that are referred from other departments, and this is called periphery referrals. Once the patient is reviewed and admission plans are ordered by the attending surgical team, nurses from the emergency department, clinic or other wards will arrange a bed by liaising with the ward nurses. Once the bed is ready in the ward, the patient will be sent up to the ward. Admission docket will contain the patient's admission slip, payment receipt, and clerking document done by the doctor attending in the clinic or the emergency department. On arrival to the bed, the nurse in charge will ensure the patient is safely transferred to the bed in the ward and will take the vital parameters to be recorded in the observation chart. The nurse will also inform you that the patient has arrived and ready to be clerked and attended to. So what is your role here as the ward house officer? As a house officer, you play quite an important role in clerking patients' history, performing physical examinations, ordering investigations, including lab works and imaging studies. Basically, you will need to ensure all orders are carried out accordingly as well. Should you face any hiccups in performing them, always remember to seek help from senior colleagues or from your team members. Admission clerking, as the name suggests, is carried out for the patients who are admitted to the surgical wards. The house officer in charge of the new patient who is being admitted is expected to review the patient within 30 minutes from the time of admission. Review the clerking which was done earlier in the clinic, emergency department or the periphery, and have an idea of the case you might be dealing with to be able to revisit the history and fill up any more information left. Review the observation chart to ensure the vital signs are charted and within acceptable ranges. If the vital parameters are abnormal or if the patient is in any form of distress, alert your medical officer or surgeon immediately. From the emergency department, usually your medical officer would receive a referral call from the emergency department medical officer. Sometimes you may be in charge of ED referrals for that day or may be also hand-chosen to see the patient first. Therefore, you will need to do a detailed clerking and perform necessary physical examinations as well and trace the investigations done by the ED team prior to your MO's arrival. In cases where the medical officers are available, they would just go along with you to review the patient. Once x-rays and investigations are reviewed, patients will be admitted to the ward if necessary or discharged with a TCA, which is known as to come again appointment. When the patient is discharged from the ED, please do not forget to order the necessary medications such as analgesics, antacids, antiemetics, or even antibiotics if needed. So how about patients from the periphery wards? Well, the patients from the peripheries may or may not be transferred to the surgical wards, but a full clerking will be needed as soon as you review them. Any plans, investigations, or orders to be carried out needs to be done by you and not the house officers from the respective departments. Discussion with the primary team on venipuncture schedules need to be done to avoid bleeding the patient twice. Well, these are the take-home messages. When you are done with your clerking and physical examinations, you will need to present your case to the MO or surgeon who comes to review. Some patients may present with wet or open wounds or wound breakdown from surgical wounds. Hence, remember, the more times you open the dressings or bandages, the more you're exposing them to infections. Therefore, the tip is to be as sterile as possible. Write or type out every point and plans given by the medical officers or surgeons. Try not to take risk by just remembering verbal orders. That never usually works. Always make notes and when possible, get your MO to review what you have written or typed just to reconfirm. Once the patient is seen with an MO or a surgeon, always write their respective names on your clerkings, such as seen with Dr. A, discussed with Dr. B, and attended with Dr. C and Dr. E. Documentations are the utmost important, therefore, pay attention to every single detail written or typed. Now let's take a look at case presentation. A case presentation is a formal communication between healthcare professionals regarding a patient's clinical information. In your housemanship training, you'll be delivering many case presentations as your communication with your superiors begin here. While delivering an oral case presentation, is a core skill for trainees, and there have been attempts to standardize the format. Expectations still vary among attending surgeons or physicians. And just like other departments, surgical clerking starts with the general clerking as well. Here we will be showing you how you will be presenting cases to your superiors for referrals or even for end of posting exams. We will also be showing you a few examples of case presentation for your better understanding. Let's begin with the opener. You should begin every oral presentation with a brief one-liner that contains the patient's name, age, relevant past medical history, and chief complaint. Remember that the chief complaint is the reason that the patient sought medical care in his or her own words. Next would be the history of presenting illness, where you elaborate on why the patient sought medical care. Describe the events that preceded the patient's presentation in chronological order. The past medical history comes next, and this should include the following information, which are the patient's medical conditions, any past surgeries, the timing of and any reasons for past hospitalization, and any current medications including their dosages, frequency of administration. How about family history? Focus on first-degree relatives, on any relevant conditions that run in the patient's family. As for social history, after the family history, this section should include information about the patient's living situation, occupation, alcohol and tobacco use, and also other substances. And when you move on to physical examination, once you are done with finish reporting the patient's history, you should begin with reporting the patient's vital signs. Next, you should discuss the findings of your physical exam. At the minimum, this should include your general impression of the patient, whether he or she appears sick or not, the results of your systemic review, which includes your respiratory, cardiac, and abdominal symptoms and signs. Next would be results of lab testing, imaging, and other diagnostics. Well, this section includes the results of any relevant lab testing, imaging, and diagnostics that were done. Finally, you should conclude your presentation with the assessment and plan. This is the most important part of your presentation, and it gives you the opportunity to show your team how much you have really understood and learned. Now let's take a look at a few examples. In the slides before, I have shown you the general case presentation. Now let's take a look at a few types of common case presentations. This is a case of a patient who presented with lower abdominal pain. The patient is a 27-year-old female who was referred from the emergency department for acute appendicitis. Patient presented to the ED due to right lower abdominal pain for 2 days and worsening in intensity associated with vomiting 3 times today. Patient also started having a fever this morning, however denies any diarrhea or urinary tract infection symptoms. There's no underlying past medical history. Patient is a mother of 2 and currently not working. So on examination, she seems to be alert with full GCS, pink, not pale, not tachypneic or tachycardic. Her capillary refill time is less than 2 seconds. She's got warm peripheries with good pulse volume. Her vitals are as shown on the slide, and her cardiovascular, respiratory as well as abdominal findings are as stated. This is another example. A case of a patient who presented with generalized abdominal pain. Now, this is a 32-year-old gentleman referred from the ED for perforated gastric ulcer. He presented with a complaint of having generalized recurrent epigastric pain for the past 1 week and started worsening in intensity today associated with abdominal distension. Denies any vomiting, diarrhea, or blackish stool, and he also denies having fever otherwise. There's no history of taking prolonged analgesics or traditional medicines, and he also does not consume alcohol. So the patient had been having frequent epigastric pain for more than 2 years now, and he frequently gets gastritis medications such as syrup MMT and omeprazole over the counter from the pharmacy. He had never sought any medical attention before. Patient works night shifts in a call center and does not have regular meals. He is a smoker and noted there's no alcohol or other drug substance intake. Now, on examination, he's alert with full GCS, not pale or tachypneic. He has tachycardia, however, with a heart rate of 108 beats per minute. The CVS and lungs examination is normal. So here again, you will need to describe abdominal examination relevant to the patient's complaint. For example, you want to describe generalized tenderness regarding the bowel sounds, whether they are present and sluggish, and no obvious organ enlargement noted. Try not to forget to perform a rectal examination to rule out any malignant stools. As for lab investigations, we note that the white cells are raised, and for the renal profile, the creatinine is slightly deranged. Any patient has normal urine analysis findings, and here you might also need a venous blood gas as well as an amylase in view of differential diagnoses that you may consider, which may include pancreatitis or an ischemic bowel. A chest x-ray can be done to look at any presence of air under diaphragm. And once you have presented your case, you can then end it with a plan given by a medical officer or surgeon. So this is how generally a case presentation is carried out. Now let's take a look at progress reviews. All patients will require a progress review. This means you will need to review patients according to whom you are assigned to. The reviews may be twice or thrice daily, so you would be assigned to beds or cubicles accordingly. Your work usually starts at 7 a.m., but it would be definitely better if you could come in a little earlier to review your patients prior to the morning rounds. You'll need to know the progress and the current issue of the patients from the day before till the morning you see them. Do speak to the patients and ask them how you feel. Also check on post-operative wounds, drain, Ral's tubing content, and quantity. These are few tips to speed up your understanding of the case before you begin your review. Ask yourself, why is the patient still in the ward? How many days is the patient in so far? How many days post-operation is the patient? How is the wound today? What have we done in terms of test and treatment? And finally, what are the future plans or advanced plans that we have for the patient? Reviews are done usually 3 times a day by the house officer in charge unless an emergency sets in. AM review is done between 7 a.m. to 9 a.m. A PM review is done between 2 p.m. to 4 p.m. And an on-call review is done between 8 p.m. to 12 a.m. Once you have done your reviews, present your review findings to your medical officer who will be doing his or her part of the review as well. There might be changes or additions to your review, and also remember to be at all times reachable. As you know, surgeons have a really busy schedule, hence sometimes they would just suddenly come in for rounds. So you will probably want to be around for your patient. Document promptly so that nurses will be able to carry out their plan as well. Next, let's look at handovers. So how do handovers work? So a handover actually occurs when a house officer hands over the responsibility of care of a patient to another house officer, for example, at the end of his or her shift. On average, handovers occur 3 times a day for each patient, and it occurs at every level of care from the consultants, specialists, and even amongst nurses once their shift ends. Handovers are very important to ensure a smooth transition, as you'll find much less disruption to team workflows and productivity rates. So what is the role of the house officer here? As a house officer, you will need to follow a well-devised format of handover to ensure pertinent information regarding the patient is not missed and to avoid wrong information passed over. There should be information regarding the past events, which means details of what has been done for the patient, as well as the patient's progress for the day or before. Present plans and events, which include details of plans that have not been carried out, blood investigations or formal reporting from radiographic imaging if there's any, and future events would be details of upcoming plans given by the specialist or MO, as well as important or urgent events to look out for on patients' conditions. Now, when service from another department is required, a request is made. House officers are assigned to make requests following the plans in the daily reviews. So how does a request work? Firstly, identify what is the test that is to be requested. Next, identify the departments involved. Then identify the officer in charge of taking the request from the receiving department. Outline the purpose of the request, urgency for the test to be done, how the test will be able to aid the diagnosis and management of the patient. Identify the criteria needed for the requested test. And finally, identify the documents that are required to be filled. These include posting a case for surgery to the operating theatre and the anesthesiology team. To place the request or orders, these are the steps as follows. Complete the request form for the test. Call or meet the medical officer in charge of receiving the request. Once granted, inform the ward nurse on the plan to transport the patient over to the location of the test or collect specimens for the test requested, And finally, document the trail, which is to who's granted the test, when the test is planned for, and preparation steps for the patient. If your request is not granted, take down the pointers to why it was rejected and convey the information to your medical officer. Your medical officer will be responsible to troubleshoot the situation. These are examples of tests that require verbal requests on your left and tests that do not require verbal requests, which is on your right. Next, let's check out referrals. So referrals are made to other departments for their management input or suggestions, or if their skill sets are required in the management of a patient. So what is the role of a house officer here? Basically, to identify the purpose of the referral, you will need to identify the departments involved, to identify the medical officer in charge of accepting the referral, to call the medical officer in charge, and to document the trail as to the time at which the referral is being made, the indication, and the medical officer who accepted the referral. Let's take a look at an example of a phone referral that can be done to the medical department. So always remember to communicate confidently and clearly to the person receiving the referral. You can start off by first introducing yourself by saying, "Good morning, Dr. So-and-so. I am Dr. Betty, a house officer from the surgical department. Here I'm calling to refer a case of Puan Siti, a 56-year-old lady who is currently admitted to our department for suspected peptic ulcer disease, who will be undergoing an endoscopy tomorrow, and the reason of referral here would be to optimize her glycemic control." You can then carry on by providing more information regarding what is the reading of the capillary blood glucose in the wards and what are her current medications. Always end your referral by thanking the team that will be coming to review the patient. And finally, we have discharges. So what is a discharge summary? A discharge summary plays a crucial role in keeping patients safe after leaving a hospital. Hospital discharge summaries serve as the primary documents communicating a patient's care plan to the post-hospital care team. Often, the discharge summary is the only form of communication that accompanies the patient to the next setting of care. High-quality discharge summaries are generally thought to be essential for promoting patient safety during transitions between care settings. So house officers are responsible for formulating a complete discharge summary and carrying out discharge work as stipulated in the summary. There are 6 main components in a discharge summary, which includes reason for hospitalization, significant findings, procedures and treatment provided, patient's discharge condition, patient and family instructions, and finally, the attending physician's signature. And now, what you need to do prior to allowing patients home, you will need to ensure that the patient's general condition is well and all plans given by the surgeons or the specialists are carried out. Remember to order discharge medications early so patients will receive them on time. This ensures a smoother process flow. Should there be a need for a medical certificate to be issued, inform your medical officer or surgeon in charge to fill the certificate before the patient leaves, as it will be included in their discharge docket. If the patient has been co-managed with other specialties, communicating the discharge plan to them will be necessary to ensure there are no clashing plans or appointments. If the patient has a wound, make sure they have an appointment or a memo of wound dressing to be given to Klinik Kesihatan or private general practitioner for follow-up of wound care. So we have finally come to the end of this session. We hope it was insightful and thank you for your time.